Recorded, and the recording will be posted on the Cost Board's webpage shortly after the meeting. TBW may also be streaming this meeting live and will archive the meeting for later viewing. And we have a very full agenda today, which can be found on the first tab of the meeting materials. And with that, I'll hand it over to Michelle Needham, who is filling in for Ryan briefly while he's just catching up from a prior meeting. I'll hand it over to Michelle.
Thank you, Ross. Good afternoon. I'm Michelle Needham, Chief Policy Officer for Healthcare Authority, just calling the meeting to order. As we dive into the agenda today, we have a brief update on some vacancies for the Cost Board. Do you want me to go over all of those? Yes, okay. We are still looking for positions to be filled for a local government representative, large employer representatives, healthcare financing representative, and a non-voting member with operational experience in healthcare delivery. So we are working closely with the governor's office to fill those vacancies. If you're interested, please submit your applications to the governor's office. They have a website that involves board applications. We also have a few adjustments to our member roster. As you may know, Jane Beyer retired from the Office of Insurance Commissioner, and Ingrid Ulray, formerly from the Health Benefit Exchange, has moved into Jane's former role, and she will be joining as a Cost Board member. So as that result, the Exchange Board member is shifting to Leah Cole-Marshall, who is here in the room with us today. Leah, would you like a chance to introduce yourself? We should have tagged you in advance. I'm sorry.
No problem. Hello, all. Thank you for allowing me to join. I really appreciate it. Filling in while we hire a permanent CEO, and then we'll have probably another change at that point, or we'll have more discussion about delegation. But really appreciate being here and all of the great work that the Cost Transparency Board does.
Well, we appreciate your engagement throughout the entire life cycle of the Cost Board, so thank you very much. I see Ryan has joined us. Would you like me to hand the intro back to you?
Yeah, that sounds great. No worries, Michelle. Michelle, always appreciate pinch hitting. Apologies for being a couple of minutes late. It's one of those days I need a clone. I appreciate that. Yes. Okay. So thank you, Michelle, for teeing us up. We are, the board has been focused, I think, as folks know, on 3 interconnected priority areas. So that being the first, primary care. We had some visitors last month to talk about that discussion. We also had some previews and some conversations on market oversight where we learned about some experiences in Oregon earlier this year, and then looking at overall expenditure and slowing the cost spending growth with specific focus on prescription drugs. Today's agenda, I think, is going to drive what folks are going to see. All 3 of those things come together a little bit more neatly, if you will. We're going to hear, we have updates from the Primary Care Advisory Committee, and we're going to hear from other experiences in Colorado around some of their efforts and primary care initiatives that their state is pursuing around payment reform and improving access, in addition to what we heard last month from our colleagues from California. And then we're going to have a conversation on market oversight, as we've talked about in the past, of looking at Oregon's model. We specifically, this group and in our subcommittee work has been looking at how health system transactions, and we define health system transactions broadly, if you will, not necessarily just those related to hospital, but lots of different healthcare activities, how those are affecting overall price and dynamics of competition in the overall larger healthcare ecosystem. I think today we're going to hear specifically from California's program, in addition to hearing from Oregon on some of the work around that, and how they have approached market and transaction oversight review. So before we do that, we are going to continue with our housekeeping, and I am going to do roll call. And if you will turn your attention to tab 1 and 2 for the next portion of this. After roll call, then we're going to do approval of the meeting minutes. So I'll do roll call real quick. The last time I checked, I was here, thank goodness. Emily Bryce. Hart Hodges.
I'm here. Sorry, it took me a while to get my mic turned on.
Great, good to see you, Hart. Leah Hull-Marshall. Great, good to see you, Leah, and welcome again. Eileen Cody.
Here.
See you, Eileen. Lois Cook.
Here.
Great. Ken Gardner. Ken Gardner. Do we have Ken? Don't see Ken. Ingrid Ulray.
Present.
Hi, Ingrid. Good to see you. And then Kim
Hi.
Wallace. Kim Wallace.
Yes, here.
Great. Good to see you, Kim. We have more than sufficient quorum. So next I'm going to ask the board's review of the May meeting minutes. Again, that's tab 2, as I mentioned earlier, for your board materials. Also just want to note, in the spirit of good government and access of government, we do have the recording of the last meeting that's posted on our website for the overall broader public to view. I will ask board members if there is any discussion on the May 28th, 2026 meeting minutes held by the cost board. Hearing no discussion, is there a motion for approval of the May meeting minutes?
So moved.
Wonderful. We have a motion on the table to approve the May
Second.
28th, 2026 meetings. Do we have a second?
Second.
Second.
Second. All in favor, aye.
Aye.
Any opposed? Hearing no opposition, the minutes are approved for the May 28th, 2026 meeting. Thank you so much for that. All right. As we normally do for our meetings, we are going to give space for a public comment period. And so for public comments that have come in for the board for your review, you will find those on tab 3 of your board books if you are following along virtually, and then in the room, if those are printed for you, tab 3 is where those are. Ross is going to facilitate our public comment period, both in terms of talking and discussing about the written comments that were submitted, but then opening up for overall broader public comment. So Ross, thanks so much. Thanks for your work. Good to see you, and looking forward to you facilitating public comment period.
Thank you, Director Moran. I appreciate that. And now we'll turn to tab 3 of our meeting packets and review public comment. Again, member of the public can sign up in advance, or you're able to raise your hand during the meeting and we can call on you as well. When called upon, we just ask that you state your name and affiliation, if any, before beginning your comments. Due to the number of speakers or potential speakers, we ask that you keep your public comment to 1 minute and 30 seconds. And you'll see that there is a timer at the top of the screen that will track that time. So please be mindful of that. The board greatly appreciates any comments that are received and considers those. So we very much look forward to this portion. In terms of any written comments received in advance, we received one written comment from the Washington State Hospital Association, and you'll find that in tab 3. And those are primarily related to the transaction review discussions that we've been having. And at this time, I want to see if a member of WSHA wanted to provide any additional comment related to that, or perfect. Kat, please go ahead. And it looks like you're being granted access, Kat. So
Oh, great. Thank you.
yes.
Oh, I don't know why I'm not on screen. That's okay. Hi, thank you. Katarina Lamarche, Policy Director at the Washington State Hospital Association. We wanted to make comments on 2 of the items, the first being Washington's Transaction Review Authority, and then the second being the comment letter Ross just mentioned about the advisory committee's recommendations on consolidation and market oversight. With respect to transaction review, we noticed that the materials in one part say that Washington only has the authority to review transactions after they occur, but we do have transaction oversight laws, which I believe were highlighted in your January meeting materials, that are required pre-transaction and apply to hospitals. And we also noted that the Providence examples and others are from 2016, before the notice of material change law was passed in 2019, and then expanded this year, which we think makes it align a little bit more closely with Oregon's requirements. And while the law doesn't give the AG the authority to modify or block a transaction beyond what is currently existing antitrust laws, we do have pre-transaction review authority. And we would ask the board, just when considering market oversight generally, that you first better understand Washington's healthcare landscape and where the problems are, and then apply policy solutions that address the gaps or needs in this state, and not just the gaps between Washington laws compared to other states' laws. And then finally, with respect to the advisory committee recommendations, like you saw, we submitted a letter that details our advisory committee members' feedback on consolidation, what might help address consolidation, and the type of study that could help assess the impact of consolidation on healthcare costs in Washington, because we feel that data is needed and would be really helpful. Thank you.
Katarina, thank you. Hi, this is Emily Bryce. Thank you so much for your remarks and your letter. I had a follow-up question for you. I noticed with interest your idea for a Washington-specific study that would help measure consolidation using Washington data. And of course, we have the Office of the Insurance Commissioner study and the Attorney General study, but I understand your point about the state-specific data. Can you think of data sources that would be available to the board or otherwise that would help Washington understand that analysis from a Washington perspective?
And it looks like Kat may have lost her ability to unmute.
I
Oh,
did.
perfect.
Hi.
Okay.
I can't remember where I left off, but based on the feedback that we got from our data folks, it would largely be the APCD, but we are speaking with a firm that's they do healthcare economic analysis on what they think the correct methodology would be and type of study to assess the effects of consolidation on healthcare costs in the state. So once we hear back from them, happy to share what they provide to us.
That's great. Thank you so much. That would be really interesting to understand because, of course, we have the well-established economic literature that I think is pretty solid at this point, but of course, always helpful to have Washington data. Thanks.
Yeah. Thank you.
Thank you, Kat. Appreciate that. And again, Wish's comments are included under tab 3 in your meeting materials. And now going to see if there's any other hands from members of the public. I see Jeb's hand. Jeb, you should be being unmuted and given access to your video. And please go ahead when you're ready.
Good afternoon, Chair Moran, members of the board. My name is Jeb Shepard with the Washington State Medical Association, representing over 13,500 physician and physician assistants across the state. As the board considers recommending a healthcare transaction review program to the legislature, I have one observation on the recommendation. As Katarina mentioned, Washington already has a pre-transfer notification process for many healthcare transactions. The legislature just this year recently revisited and significantly expanded that framework through House Bill 2548. So I would encourage the board to allow time for those changes to be implemented and evaluated before recommending additional statutory changes. More broadly, we continue to encourage the board to examine the upstream cost drivers that are contributing to consolidation in the first place. Several of those drivers are within the state's control. I've mentioned here before that independent physician practices have experienced a 40% increase in B&O tax since 2019. Medicaid reimbursement often does not cover the cost of providing care. These increasing costs are making it increasingly difficult for independent physician practices to keep their doors open. These practices are embedded across communities in Washington, providing accessible, high-quality care, keeping folks out of higher cost settings. And it's becoming more and more challenging to keep their doors open. It'll be more difficult when HR 1 is implemented. And they're faced with few options: either close their doors, reduce access in their communities, or seek affiliation or acquisition by a larger organization. My request would be that as the board prepares this report to the legislature, we once again include request that a dedicated section on these upstream cost drivers is included. We've repeatedly made that request, yet those reports continue to focus primarily on consolidation trends and market impacts without adequately examining why consolidation is occurring. Thank you.
Thank you, Jeb. Appreciate that. Are there any other folks that would like to provide public comment today? Just wait 1 minute to give folks an opportunity to raise their hand if they'd like to provide public comment today. All right, not seeing any additional hands. I want to thank everyone who provided comment, and please feel free to reach out to us via email or submit comments, and we'll include those in next meeting's meeting materials. Thank you, and I'll hand it back to Ryan.
Great. Thank you, Ross. Thank you, members of the public and others for being present to weigh in on important topics. Now we're going to hear from the Primary Care Advisory Committee. It's been helping the board explore the work around strengthening primary care in Washington State with focus on affordability, access, and equity. Again, the key pillar of this particular work is to think about primary care spending trends, some of the workforce challenges, and the relationship between primary care investment and the other market dynamics that exist. So I'm going to turn it to Dr. Judy Zerzan-Thule, who is the Chief Medical Officer here at the Healthcare Authority, to discuss and review the work out of the Primary Care Advisory Committee report out from June 25th when that group met. Judy, are you on? I'll see Judy. Okay. Are our colleagues from Colorado on the call yet, or were they joining at a later time?
They are here.
They are here?
Yes.
Okay, great. Why don't we move to our Colorado presentation? Maybe Judy had a mix up in terms of the time. So we will much anticipate awaiting the Primary Care Advisory Committee's report. But while we hold on to our seats, we are going to welcome our colleagues from the state of Colorado. We're pleased to welcome Devin Kepler from our sister agency, the Colorado Department of Healthcare Financing and Policy, regarding the work of some of their primary care initiatives. I think the important thing to note as we turn it over to the team from Colorado and others may be joining, they pursued a number of initiatives that the Primary Care Advisory Committee wanted to bring to this particular group of about how they are strengthening primary care, other ideas and thoughts for states to think about alignment across payers and supporting practices along that particular journey. And so as we do often in the board spaces, a review of what is happening in other states helps us here in the state of Washington think about how can those particular frameworks, not necessarily full adoption of these types of things, but how can they support thinking about the challenges that we have in our state to improve them in the future. So I'm going to turn it over to the team from Colorado. We are grateful for your wisdom and your expertise, and we look forward to hearing what you have to say.
Well, great. Thank you so much for that introduction. Can folks hear me?
Yes, we can hear you. Thank you.
Okay, great. Well, I think I am slated to kick things off for the Colorado contingency. I wanted to start with a thank you for inviting us. I would echo those sentiments about being able to speak with and learn from other states. That's certainly been a critical part of Colorado's journey. So we're thrilled to be here with you today and look forward to sharing our experiences and hopefully having a little bit of a dialogue. So you're going to hear from several of us today. I am the first name you see on that slide. So my name is Tara Smith and I work at the Colorado Division of Insurance. And so I can kick things off by setting a little bit of context around Colorado and sort of our history when it comes to primary care delivery and payment reform. Talk a little bit about a group that I lead here, our Colorado Primary Care Payment Reform Collaborative, and some of our activities in the commercial space before handing it off to my colleagues at our state Medicaid office from the Department of Healthcare Policy and Financing, so they can fill you in on some of the exciting work that they have been doing. So if you want to go ahead and go to the next slide, we can go ahead and dive right in. All right, we can go to the next one. So as with any good presentation, I thought I would start with a slide that has way too much information for anybody to be able to visually digest. But thought it was important to just start with a little bit of context, and timeline can be a great way to do that. So you see the timeline there in the middle of the slide. Really the two key takeaway points from this. One, the activities you see above that timeline are all state-led or state-driven efforts. And I think you see from just going back to 2027, honestly, I probably could have extended that timeline back another 10 years, but it wouldn't split on the slide. Is that Colorado has a very long-standing and robust history when it comes to really working on and putting forward advanced primary care delivery models, and kind of in tandem with that, thinking about different types of payment and payment reform that can sustain and advance that type of advanced whole person-centered primary care delivery in our state. So a long, robust history and a lot of work that we've been iterating on over multiple decades now. Second key point from this, everything you see listed kind of below the numbers on that timeline are some of the big federal demonstrations. So some of the models that came out of the Centers for Medicare and Medicaid Innovation, CMMI. For a key part of our history, they really served as a foundation or backbone for our state's work. So we were big in comprehensive CPC, you see there, comprehensive primary care, the comprehensive primary care plus model. And that really served as a way to anchor our reforms. As we've moved forward, we were not as big a state in primary care first. So we're kind of starting to see that shift a little bit, even starting in the early 2020s. We got excited by the brief shooting star across the sky that was making care primary. We were one of the states that was going to participate in that, but as we all know, that was not continued under the Trump administration. So the work that I'm really going to focus on is really that primary care payment reform era, collaborative era that started in 2019. And I would say a big focus of our work has been thinking about how do we build out that platform, that infrastructure, that coalition of partners that are going to really be engaged in and prioritize primary care as a state in the absence of that kind of big federal model or funding that kind of served as that coalescing force. So if you want to go ahead and go to the next slide. So this primary care payment reform collaborative chapter, I'll call it, really began for us with legislation, which enabled regulatory tools. So as you're talking about and thinking about with other states about their primary care efforts, I think one of the things that makes Colorado a little bit unique is that we have had some great legislative champions, and they, through different bills, I'm going to talk about two of them here, have given the Division of Insurance regulatory tools in this space to be looking at and having some leverage over the commercial payers, which are a huge part of this project. So I think that's kind of a unique thing you can take away from Colorado. So this bill in 2019, really, there are two key things that it did. One, it created this primary care payment reform collaborative, which is a state-based multi-stakeholder forum, which is really tasked with making recommendations for our state on how we can improve access to high-quality primary care. Second thing it did, which is also very important, it gave the Commissioner of Insurance the authority to include affordability standards as part of our rate review process. And kind of cited in those affordability standards specifically was setting a state investment target for primary care. So I think people know rate review is a very powerful tool as a state. So it really introduced that element into our conversation here in Colorado for the first time. So if you want to go to the next slide. So in terms of the primary care payment reform collaborative itself, I will start calling it the PCPRC just to save a little bit of time. Again, it's a multi-stakeholder group. It includes payers, providers, and consumers. In terms of payers, that's a mix of both private and public. So our state Medicaid office has a seat. We have a seat for our federal partners at CMS. And then we've had different commercial payers kind of roll on and off. A lot of those have been the Uniteds and the Anthem. Anthem has not been a part of it. But we've had some of the larger national commercial payers. Denver Health, which is one of our more regional payers, has also had a seat on that over time. In terms of clinicians and providers, we have had both adult and pediatrics as part of our conversation. That actually dates back to some of our work on the state innovation model, having pediatrics be an important voice in our conversation. We have just added a nurse practitioner to that mix, so really trying to get a range of perspectives across different clinicians. The responsibilities you see here are some of the tasks that they were assigned statutorily. So that first one is key in terms of advising the Division of Insurance as we are developing those affordability standards and what we set as our target investment in primary care, which I'll get to in just a minute. They have also played a key role in how we are thinking about collecting and analyzing the amount of primary care spending in our state. So that involved first, how are we defining primary care? And then how are we looking at that as a percentage of total medical expenditures? And then you see there are a couple of tasks related to the use of APMs and how we can be increasing APM adoption as a state. So if you want to go ahead and go to the next slide. One of the things that was also created in 2019 as part of that legislation is a framework for analyzing and collecting data about primary care spending. So Colorado is one of the states that has a pretty robust and long-standing APCD. So we wanted to leverage that tool. So that they were tasked with collecting primary care spending. That information is broken out across by line of business. So for commercial carriers, for Medicaid and CHIP are the three required. We have also been able to include Medicare Advantage as a different line of business, so we can get a little bit more nuanced picture of what what primary care spending actually looks like in the state. And we are one of the states that includes both claims and non-claims based spending as part of that calculation. And so including the payments that are made through APMs or that are not on a fee for service or per claim basis. So if you want to go to the next slide. So here's the way that we do that. You can see as the dark blue box, that is our definition of providers that are included in our primary care spend numbers. It's one of the broader definitions, right? I know not all states include OBGYN is one of the categories that we include, and also behavioral health providers in integrated settings. So a broader definitions would mean our percentage is a little bit higher. Again, you can see we include that claims and non-claims based spending, both in the numerator and wow, hard to say that this afternoon, numerator and denominator of that calculation. So if you want to go to the next slide. So for the first 2 years of work, the collaborative was really focused on, okay, let's get our definition, let's get some spending and parameters, let's get a couple of years of data in place before we set a primary care investment target. And so based on their recommendation, the division promulgated this initial regulation 4272. It was promulgated at the end of 2020 to be effective as of January 1st, 2021. And Colorado decided to make it an incremental target. So rather than saying we want everybody to be at 12% or 15%, states have had various percentages. We followed, Rhode Island was the model that we had looked at, which said we know primary care spending is too low. We don't know what that target number would be. So we're going to require carriers to increase the percent of total medical expenditures that are allocated to primary care by 1 percentage point in 2022 and 2023. We also, within that target, within that requirement to increase that investment, set a target of, as you're increasing that spending for your primary care expenditures, we recommend, it was a target rather than a shall in the regulation, should be going through prospective payments. At the time we were promulgating this, the DOI, we had thought about setting an equivalent target or some sort of target for APM expenditures and stopped short of that in our initial regulation. We again put forth kind of this target, this recommendation, which said carriers, about 50% of your total medical expenditure should be going through APMs by the end of 2022. It was a very broad definition of APM, so we weren't specific. And then of that amount, again, about 10% should be going through prospective payments. You remember end of 2020 when we were promulgating this, COVID was still very much upon us and really a powerful demonstration of kind of the value of prospective payment. So next slide. So one of your questions to us in advance that we got was, well, what data do you have? You know, have you seen, how is this target impacted spending? How has it impacted costs? I don't have data for you on costs, but I can share with you what we've learned so far around spending. So each year our APCD provides to the division and the primary care collaborative a report on the level of primary care spending. It's APC data, so it's looking back a year, and we collect 3 years of data from carriers. So from our most recent report, which had the data from 2024, we got the report in November of last year. As a state, we're sitting about 15.7% based on APC data of total medical expenditures that are flowing through primary care spending. You see two different figures here because Colorado is a state that has 2 of our big payers have integrated delivery systems, which can really kind of skew those numbers. So we usually report those out separately. This year, we found that percentage didn't really vary that dramatically when those 2 payers were either excluded or included. So if you go to the next slide. This is where the ability to break that out by line of business becomes very important. right? 16% people are like, you guys are doing great. You're crushing it here in Colorado. But kind of understanding what that looks like across the different markets in our state becomes very important. And so you can see from this slide the different kind of lines of business that we've tracked over time. And you can see Medicare Advantage has had we had a huge spike. We actually had a spike going into 2020. And then that went up even more between 2023. So it very much influences that overall figure that gets reported out as our primary care. The other line I'll point to there is that red line at the bottom, commercial spending, that shows that we haven't really seen much movement around that figure. It's always hovered somewhere between 8 and 9% from the time we started initially collecting this data back in 2019. So if you want to go to the next slide. One of the nuances we've added to our spending, our target was in a percentage, and we talk a lot about percentage of total medical expenditures, but we also started wanting to look at that at a PM level. So as states are thinking about it, that's one of the features you could consider in terms of reporting. If you want to go to the next slide. In terms of APMs as a percentage of, and I'm sorry, I should have changed the name on this slide. So what you're seeing here is actually the percentage of APMs of primary care spending. So it's not total, but of carriers' primary care spending that they're reporting to it, almost 60% is flowing through value-based payment models. We do exclude, we use the LAN reporting categories, which I know have been sort of retired. But that blue bar you see, that 4N, that's actually not tied to any value, so we don't actually count that. But so we are reporting about 60% is flowing through APMs. I will tell you, providers on the ground find suspicion in this data. That doesn't tend to be a kind of their lived reality in terms of the amount of their contracts that they actually see through APMs or value-based payments. If you want to go to the next slide. One of the other things we tried to add in, and again, I'm sorry, I need to update the title on this slide as well. This is the amount of prospective payments that are flowing through primary care spending. So we added a flag to our reporting that asked about how much of those payments were collected through prospective payments. Again, we get a very high figure here, which again, providers will tell you is not their actual experience. But we're trying to look at spending from various different lenses to see what that has looked like over time. So I just wanted to kind of give you a snapshot of what we're able to tell about how kind of our tools and our lever around the investment target and the other ways we're encouraging increased spending, what that looks like in some of our data. So looking at the clock, I'll keep going pretty fast here, and then kind of if people have questions, we can get to them after. I would say the other key regulatory tool that we developed, again, through a piece of legislation, this time in 2022, was the ability as the Division of Insurance to set aligned parameters for APMs that are used for primary care services across commercial payers. So the thinking here was, now that we have this tool, we're trying to increase spending for primary care. We're trying to do that when we can through value-based payments to be driving volume into the system. If we're doing that and each payer in our state still has models that aren't aligned, are we actually just making the pressure worse on providers rather than helping them, right? So payer alignment has been a huge part of our story. Again, think about that timeline, multi-payer dimensions to each of those activities. Now we have a regulatory tool in that space to do it. So the division has developed these aligned parameters. You can see on the, I guess that would be the left-hand side of the slide, the 4 areas. So around risk adjustment, around patient attribution, around core competencies, and around aligned quality measures. So all commercial carrier contracts now have to meet certain aligned principles around those 4 key elements. 2025 was the first year they were required to incorporate those into their contracts. So we don't have a ton of data on that yet, but again, another kind of important tool for us as we're thinking about moving forward. So if you want to do next slide. I know you had to ask a question about rural providers to us as well and workforce. That's a little bit outside of the scope of the collaborative, but rural issues and certainly workforce as well has been an area, has been kind of an underlying theme in all of their work. So in their most recent annual report, they did have some recommendations that were specific to rural providers and supporting federal and state funding for rural workforce and education and training. So it certainly is something that's been on our radar, but from our perspective, it's an important piece of our conversation, but it hasn't really been the focus of the collaborative. So if you want to do the next slide. I think moving forward, the collaborative, when it was created in 2019, was initially scheduled to sunset this year in 2025. So that's a mechanism in Colorado state law where legislators can go back and say, hey, was this thing effective? And if so, they can continue it. And if not, it can go ahead and sunset. They decided that they wanted to continue the collaborative through 2032. And so just have some key themes listed here as we're thinking about moving forward into this next iteration and key topics that are coming up. One is around consolidation in the market and how does that impact basically everything in primary care, but particularly things like primary care spending, right? If we're setting a target, but we're seeing through systems that money isn't actually flowing through to the providers on the ground, do we need to be thinking about that in a more nuanced way? AI, a big part of our conversation, HR1, obviously huge implications. And then one of the other things we're looking at is looking at creating a comprehensive primary care strategy for the state, which would include payment and investment, but would also then fold in workforce, access, some of those other components of primary care. So we're actively looking at that right now. I will end very quickly with some just some key lessons that I would offer to other states on the next slide. Legislative champions have been important to us, but you need to be thinking about building that pipeline as well. When that person gets turned out or leaves, not having somebody strong to step into that can lead to a real vacuum. I would say when you're measuring primary care spending, don't let the enemy be the perfect of the good. I think we could annually be talking about whether or not to include OBGYNs as part of should we be including pharmacy as the denominator? So important considerations, but I think also moving forward with being able to start tracking some of this spending, even imperfectly, is important. Learning from peers is why we're here today, and the latent larceny is one of the monikers that goes by here in Colorado. And then I think as a division of insurance, really thinking about how we are bringing carriers to the table. We do have some powerful regulatory tools now, but how are we balancing those with carrots to really entice commercial payers to come to the table in good faith and really pick up our efforts. So I will stop speaking there and hand it off to Matt.
All right. Thank you, Tara. And thank you, everybody, for having me here this afternoon. My name is Matt Sundin. I'm the Program Management Section Manager in Colorado's Department of Healthcare Policy and Financing, or since that's a mouthful, HCPUF, as we call it here. I am going to talk to you today about our Accountable Care Collaborative. You can go to the next slide. Which is our program to implement Medicaid in the state of Colorado. HCPUF is the single state agency that implements Medicaid or administers Medicaid as well as CHIP Plus. And for a little additional context, we've got about 1.2, 1.3 million members enrolled in Medicaid now in Colorado, so about 20% of our state population. Our Accountable Care Collaborative is our main tool that we use to implement our Medicaid program. Through it, our goal has been to really ensure that we're having coordinated, high-quality care that's delivered at a regional level that's responsive to our member needs. And through the program, we're facilitating all sorts of arrangements with our providers, with health plans, with community partners to make sure that our members are getting the services that we want them to get and what they deserve. So the main component of our Accountable Care Collaborative, or the ACC program, are regional accountable entities, or RAEs, which are essentially health plans that we contract with to administer the program throughout the state. So there's a couple of main functions. One of the main functions that doesn't really directly relate to primary care, but they administer a capitated behavioral health benefit. But they're not devoid of responsibilities on the primary care side. So they're also responsible for contracting with a regional network of primary care providers that serve as the medical home for our members. And so the RAs are responsible for contracting with them, but also providing care coordination so that as members are toggling back and forth between different types of services, the RA can help them coordinate their care, coordinate work with different providers, community organizations that might interact with the members. So you see up at the top of the chart here, we have our RAs with those types of responsibilities. They're coordinating care with our members so that members can appropriately access their benefits and their services. And then they're also working with both behavioral health providers and primary care providers to make sure those services are being delivered appropriately. The RAs are managing networks with those providers, making sure, and also delivering some sort of payments to those providers. And we'll get into some more detail about that. If we go to our next slide. So, like Tara, I also like to do a little bit of a timeline type of slide to get you all acquainted with what's happened in our state. But our history with the ACC program and Medicaid managed care goes back, a couple decades. We can certainly go back to 1995, where we established our initial Medicaid mental health capitated program. We had a brief period in the late 90s where we had full-on managed care throughout the state, but that encountered some legal challenges. And in 2000, we ended that full-on managed care arrangement. In 2011, we started the Accountable Care Collaborative. And with our initial phase one. And I think the key part of that is we had two sides of the shop. We had our managed care for behavioral health in different organizations that were implementing that program. And then we had our managed care for primary care in different entities implementing that side of the shop. And we did that for 7 years and came to the understanding that, hey, wouldn't it be great if we only had one entity that was helping to administer the program, regardless of whether it was primary care or whether it was behavioral health. So in 2018, we launched our ACC Phase 2, a 7-year program as well. And that combined administrative functions for both the behavioral health capitation and the primary care coordination component of our program. We enrolled most of our members in the ACC. As our program continued to grow and our membership in our state expanded under the Affordable Care Act, most of those members were enrolled into the ACC program and were assigned to work with a RA or one of our managed care organizations. In 2025, July of last year, we launched ACC Phase 3, and we've made further enhancements to our program. And we'll talk a little bit about what those look like and how it relates to primary care. Interestingly, I know Judy's not here right now, but she was our CMO for a large part of that timeline. So I guess if you ever wanted a deep dive into Colorado, you can talk to Judy as well. If you're interested in Colorado and know a little bit about the state, here's how we divide it up amongst our regional accountable entities. In phase 2, we had 7 of them. We're now down to 4 of them to try to simplify some of our administrative burden on our providers. So while a couple of them really look large geographically, they're actually our smaller population RAs. The larger population RAs are those Region 3 and Region 4, which are around the Denver metro area. So again, about 1.2, 1.3 million people. The last thing I want to note on this is that we have 2 other entities that are involved in our program. Out on the western slope of Colorado, we have Rocky Mountain Health Prime, which is a capitated primary care program. So they don't do the behavioral health benefit, but they're carved out of our RA. So the RA handles behavioral health with a capitated payment, and then the managed care organization, Rocky Mountain Prime, does primary care for a fairly defined population. And then in our Denver area, we have Denver Health, which operates a hospital system, but they also have a health plan, and they also do a capitated or receive a capitated payment for primary care. Members getting behavioral health services are covered by the RA in that region. So that's how we break it out in our state. If we go to our next slide. So while I mentioned RAYs are largely responsible for paying on behavioral health claims, and that's a big part of their work, primary care is also a key component of the work that they do. Thinking back on the history of the program in our state, we really didn't want to have this division for our members. We wanted to make sure our members and our providers had more of a seamless interaction with the department in receiving their services. So our RAYs are responsible for contracting just within their geographic region with a network of PCMPs or primary care medical providers, which serve as the medical home for all of our members or many of our members. So the PCMP is supposed to be their focal point of care and help the PCMPs help our members connect to preventative care services. They do chronic condition management and provide other supports to our members. The RAYs are responsible for ensuring that we have an adequate network of PCMPs so that members can get better access to their services. They're also responsible for supporting their PCMP network. So to be a PCMP, you have to meet certain standards in the RAY contract. And so the RAYs are responsible for making sure the PCMPs meet those standards. They also work with the PCMPs to make sure they have access to condition management programs. So there's a number of conditions that are prevalent within the Medicaid community, and we want to make sure that our members can have access to programming specific to those healthcare conditions. In addition, the RAYs are responsible for working with the broader health neighborhood to make sure that even if the member's not getting service directly at a PCMP, that they can go to other providers, specialty providers, community organizations to get their needs met. So there's really a critical role for our RAYs to interact. I'll also, by the way, point out that our logic for connecting people to the RAYs is dependent on, in large part, on where they're getting the members are getting their services. So there's a whole attribution logic that's assigned to that based on where the PCMP is located. And we really press our RAYs to make sure that members who are assigned to them are getting connected to a PCMP to get better services. I think a lot of what we are trying to accomplish here is that our members are better connected to the focal point of their care, so that they're getting higher quality services, that they're managing their chronic conditions. Overall, that's supposed to improve outcomes for our members, but also improve in the long run the costs that are being assigned to the Medicaid program. We know that members who are connected to their PCMP can get better connected to specialists because the RAYs are involved. They can connect to behavioral health care supports as well as other things like SNAP and WIC and other social supports that are within the social safety net services that Colorado provides. We also know that PCMPs are better equipped because they're getting support and investment from our RAYs to deliver high quality services to our members. So we really want to make sure members are connected to their PCMPs. And it's been pretty well documented in our data that when members are connected early to PCMPs, their healthcare needs are identified earlier, and we can reduce the overall costs of our program. If we go to the next slide. So I think what we wanted to accomplish with this slide is really talk about our primary care payment structure. So I mentioned a RAYs contract with a PCMP network, but they don't contract with all primary care providers in the state. They only contract with the primary care medical providers who meet certain standards in our contract. But all primary care providers, when they're providing a physical healthcare service to one of our members, will bill directly to the department for that service. They're not billing the RAY. If they are contracted with an MCO, that Rocky Mountain Prime or the Denver Health, they would bill that MCO. But that's actually a pretty small population. There's about 130,000 members who are in one of the MCOs. For the most part, when primary care services are delivered by a PCP, whether it's a PCMP or just a PCMP, it's billed directly to the department. And so you see in fiscal year 24-25, that's about $500 million in claims payment just for direct billing to the department. Our PCMPs also get payments from the raise. So we have fixed dollar amounts that we pay out on a per member per month basis to our raise. The amount differs per region, but it's in the neighborhood of $12 to $19 per member per month. We pay that on to the RAY. The RAY has a requirement that at least 33% of that payment is passed on to the primary care network. The RAYs are also making payments directly to the primary care medical providers, and that's to provide administrative support and help to support our members. The reality is most of our RAYs are passing through more than that 33%, but the minimum requirement is 33%. Last fiscal year, that was about $150 million that was paid through by the RAYs to support our primary care medical homes. And then we also have our quality program. And this is our methodology for incentivizing both our RAYs and our primary care providers to improve their performances related to our members. In ACC Phase 2, we paid it out regionally. So our RAYs were the ones who got that payment, and then they would pass it on to providers. And we really measured everything based on regional performance. In ACC Phase 3, we've changed that up a little bit. There are still payments that are going to our RAYs for their regional performance, but we are also measuring the performance of individual PCMPs. And so we're able to measure the outcomes for our members who are visiting all the individual PCMPs. We have a number of different metrics that we're measuring them on, and then they're eligible for payments based on the performance that they have. So there's a number of different ways that our primary care providers are getting paid by the department. Go to the next slide. So as I mentioned, we just launched ACC Phase 3 in July of last year. So we're a little more than a year into the experience. And we've got a little bit of data on how it's performing, but really the plan here is to do a longer term evaluation on the project or on the program to get a better sense of how it's supporting our members, how the work is being performed by our providers. So we've really made data informed decision making a key part of our contracts with our RAYs. We've developed a number of different performance standards, including performance standards on how they're interacting with our primary care medical providers, how they're performing on our different quality members, the cost of the program and utilization trends and things like that. So we're going to have a much better sense probably a year from now, certainly 2 or 3 years from now, on how the program is performing and whether we're reducing costs throughout the program or not. And improving outcomes for our members. At the end of the 7-year period, we've developed an evaluation that we're going to be implementing throughout the program. And through that evaluation, I think we should have some really comprehensive information about how the RAYs perform the responsibilities around behavioral health, care coordination, and primary care. That'll include both quantitative and qualitative analysis. And so I think it's going to be pretty exciting to see, if all of these changes that we've made and the investments that we've made both in primary care and behavioral health are ultimately paying off with better outcomes for the state. So I don't know if I have another slide. Yeah, one more slide here. So some challenges that we're having that probably I think are not just exclusive to Colorado. But in the Phase 1 and Phase 2, we were able to do some analysis on avoided cost and cost savings, but it's not something we've been able to replicate in Phase 3. We're going to have our evaluation plan, but some of our cost savings analysis in Phase 1 and Phase 2 was based off of prior models without that managed care component. And so it's much more difficult to get to that analysis in Phase 3. We're exploring different methodologies, but it's a continuing challenge particularly related to primary care. We're focusing a lot on improving our quality program for the RAISN providers, but we're also finding that that comes with some challenges from our primary care providers. We're already anecdotally starting to hear some of them complain about the additional administrative burden involved. It's interesting, they're complaining about the administrative burden, but we didn't set up the direct payment to them in a vacuum. We actually heard from a lot of providers in phase 2 that they wanted to be measured on their own individual performance. So we've executed on that, but now they're telling us that it's more administrative burden. So feels a little bit like a can't win situation for us, but I think something that we're continuing to address. Another challenge that we had at the start of phase 3, we thought we would have access to funding for what we called our access stabilization payments. And these were payments specific for our PCMPs who were operating in rural communities, or they were small PCMPs, or they worked with our pediatric population. A lot of these were sort of challenged to participate in value-based payments prior because they weren't big enough to participate or didn't have big enough populations. And as we've seen in a lot of places, it was really difficult for them to continue to operate and keep their doors open. We thought we would have payments we could make to them, but there were some federal challenges. We ultimately didn't get approval from CMS to go forward with those access stabilization payments. And so while a number of those providers were sort of counting on those payments to help them go forward, they weren't available through the state, and it added an additional complication to our program. We've also been playing around with prospective payments, and something more that we've been doing in our behavioral health space and less in the primary care space to try to provide some revenue predictability to our providers. But a lot of those prospective payments aren't really enough to support practice transformation just by themselves. So we have to sort of intertwine them with other payments that we're using. And that's another challenge that we're having in the primary care space. Finally, we talked a little bit, or Tara talked a little bit about shared savings programs. And we have shared savings set up with our finance office and working with our providers where they can get reimbursed for shared savings that we're realizing across the program. But again, there's some implementation challenges that we have with the shared savings program. I think I would probably defer to some of our colleagues in the finance office to describe more of those, but these are things that we're working through as we go through ACC phase 3. I think that might have been my last slide. You can click forward. Yep. I think at this point, I'll hand it off to Rachel to talk about a specific project related to integrated care.
Yeah. Hi, everybody. My name is Rachel Shuck, and I am the Integrated Care Section Manager for Healthcare Policy and Financing in our Behavioral Health Initiatives and Coverage Department. Subsequently, I also am co-working, and I'm the Strategic Initiative Manager for the Colorado Rural Health Transformation Program. And the reason is because this integrated care sustainability policy kind of backs up onto what Tara had talked about, the state innovation model. So House Bill 22-1302 came out of ARPA funds, and it came from the state innovation model, or SIM, because after SIM was over, we proved that integrated care does save funds. It does save money to Medicaid. But then there was not significant policy changes that followed behind that. And so with these last ARPA dollars, there was $29 million that was provided to give out to organizations within Colorado to either newly implement integrated care into a primary care setting or expand their care into a primary care setting. And so this grant ends December 31st, 2026. So we're coming out of the last 6 months. So go ahead with the next slide. So what Colorado did have during the first initial iteration with the state innovation model is they started what we called the 6 short-term behavioral health visits. And so there was no diagnosis needed. You billed straight to the department. And then after those six visits, then you build across to your RAE. But it wasn't intended to support integrated care itself by just as a whole. It doesn't offer options for shorter assessments or interventions, those brief interventions. And a report that we had done by the Farley Center showed that was really, really low utilization. It was less than 2% annually that these psychotherapy codes were being used. So next slide. So what does our change do? And we're going to talk through all of it, and then I'll give you our website. So all of our psychotherapy codes, formerly those 6 short-term behavioral health visits, they got moved over to the RAE capitation. So now if you're coming in for a routine appointment to your primary care and you're going to see your behavioral health provider, they just bill directly to the RAE for that 45-minute to hour-long meeting. And after the 24th visit in 1 year, then they would have to receive a prior authorization. And then we work to create additional per member per month to support highly integrated practices with non-billable interactions. And then we opened codes. So we opened the hca, or Health Behavior Assessment and Intervention. COCM is the collaborative care model, and then a couple of other BHI codes to allow for those shorter, brief interventions. So walking in the door, when you say, yes, I am sad, depressed, down, lonely, or blue, instead of receiving a referral to call a therapist, somebody walks into the room at that time. And then the collaborative care model code makes it an efficient use for really difficult psychiatric services. And that can all be done even via telehealth. Next slide. So this slide just shows how we presented this to the state of Colorado. So if you are a PCMP, and this is only right now, this is only open to our PCMPs at this time. The goal is to continue to prove to legislation that we are saving funds so that we can open it to specialty. Certain places, especially OB clinics, would very much so like to have the use of these briefer intervention codes. So we're working on that. But for right now, we created this practice assessment that the PCMP completes with their RAE. They can bill the psychotherapy codes directly to their RAE, and then they bill those hobby, as we call them, or COCM codes directly fee for service to the department. And then you see how the payments come back through. Next slide. So on our practice assessment, I'll show you a couple of different slides. We did a 3-tiered assessment to incentivize progress, and it aligns with CMS, DOI, and the Bodenheimer building blocks. So the recognition will be counted towards each of these tiers. Next slide. So the care delivery domains, we had to have all of this inside of each of the care delivery domains. As I let you look at it, we used this to then turn around and build the practice assessment that will be completed annually with each of the PCMP providers and their regional accountable entities. Next slide. So what is our integrated care PM? They must meet all 3 criteria, and I'll show you that in a moment, to be eligible for this integrated care advanced payment. It's intended to cover the cost of services that are typically non-reimbursable. So those curbside consultants, doctor walks out, asks to speak to a provider, intervention less than billable minimums, select care coordination, referrals, and follow-up tasks. Next slide. So this is a very simple way we asked them. We asked 3 questions. Do you have an established relationship? Does the practice have identified interdisciplinary team? And then the third, does the provider implement protocol for effective information between physical health and behavioral health? If they can answer yes to all of those, they will receive an extra PMPM payment through the integrated care benefit now. Next slide. So I believe this is my last slide that I wanted to show. So our new policy was passed last July for the beginning of our fiscal year. So we are just 1 year into utilizing these codes. We've had to do a lot of education and training. We've had to go out and explain how to use these hobby codes, the needs behind the collaborative care model codes, the tracking that is required behind it. And for our first year, we're pretty impressed with our billable encounters. We're averaging about 1,300 per month so far. Data is going to vary a little bit, but again, this is July through March at this time. FQHCs are using this a lot, but the hobby codes are by far the most utilized code that we have. They are 92% of the encounters, because then that eliminates the need for that psychiatrist in there. So if you would like to see what our policy is, I don't think I have ability to put anything into the chat. So if you want, I can just tell you our website, and on the front page, you'll see in the middle of our front page, Integrated Care Sustainability Policy page can be found at hcp.colorado.gov/integrated care. And that's all one word. And then from there, that shows what we've done with the work with House Bill 22-1302, but it also has our policy page, so you can see our entire policy for both. And I believe that was my last slide. Yes. I think it's open to questions to Tara, Matt, or myself if anyone has them.
Yes, and thank you so much, Tara and Matt and Rachel, for that. Do cost board members have any questions? I see Ingrid's hand. Please go ahead, Ingrid.
Thank you, Ross. Thank you, Colorado colleagues. This is super helpful, really interesting. I wanted to jump in first because I have to leave soon to go to another meeting with Commissioner Cooter, but was curious, and maybe Tara, you could answer, or your colleagues, of sort of the complexity of the approach in Colorado. You've had a lot of success. I'm curious, when you think about the move to prospective payment as well as the alignments that you described, how does that compare to a model that would just create more of a common fund like we saw described recently in the JAMA article, Primary Care as a Public Utility, by Zuri Song and colleagues? Are you familiar with the article I'm mentioning?
I am familiar with the article you're mentioning. Yes, thank you for the question. It's been a minute since I've looked at it, but I think that sort of idea of primary care really as a universal common good and finding a different kind of source of funding for that, whether that's, I think we have had some conversations about that type of approach in Colorado, kind of creating this care hub, and commercial payers would sort of pay into that, communities might pay into that, right? Kind of really getting at getting outside of, I would say, the traditional kind of payer-provider relationship. And in Colorado, a lot of our focus has been moving that relationship away from fee-for-service, but into a different type value-based payment models, which, again, without alignment, create their own source of frustration and complexity for providers that, we're continuing to consistently hear, even through the actions that we have taken to try to align those. I don't know that those are fundamentally at odds with each other, but I think there's a definite kind of transition and shift that would need to occur to be able to kind of bridge that gap and get into that new way of thinking that that kind of common good or that approach would take. We just did, we are in a year of a governor election here in Colorado. We have a candidate that is very much putting primary care forward as part of a platform and using terms like universal. So I'm not sure if we're kind of headed in that direction ourselves as a state. it's something I've thought a lot about, right? Like you look at that timeline, all this work, I would say, 90% of that is great for us, but I almost wonder if that kind of does make it a little bit harder for us to kind of make a shift in our thinking that would be a little bit radical rather than just kind of continuing to build and build and build on past work. Is it actually going to take a different kind of spark to get us thinking in a different direction? Because I don't think as a state, outside of some preliminary conversations, we've really kind of started exploring that route. I don't know if that answers your question, but I think we are still, we have not entered kind of that new phase of thinking around primary care.
Great, Tara, thank you. Good to see you again. Appreciate it.
Yeah, likewise.
Thank you, Ingrid. Hart, I see you have your hand up. Please go ahead.
Yeah, I've got a couple of questions for Tara, but I want to start by saying thank you all so much. I'll be interested to watch and learn more about, see what happened, learn more about the per payer resources for non-billable interactions. I think that was very interesting. Tara, you apologize for not changing a title on a slide. I actually preferred the first title. Are the alternative payment method targets for all healthcare or just in primary?
We set it for both. So we had it
Okay.
as a percentage of total medical expenditures, and then also talked about primary care specifically. So
No,
we kind of looked at both.
Yeah, I think that's probably crucial as the literature has revealed. And I'll ask you, but it may be a question for everybody, you showed that increase in Medicare Advantage expenditures. Is that viewed as a good thing, or is there a dose of skepticism given some of the articles on unnecessary or extra care in Med Advantage plans?
I would say there's a healthy dose of skepticism, right? In terms of what that means and how that's actually played out, and is it actually led to improvements in patient care and patient outcomes? So.
Okay. I hope I get brownie points. I'm sitting in Grand County, Colorado right now. So thank you all.
Wow. Okay. Excellent.
Thanks.
Hopefully our skies aren't too smoky up there.
Thank you so much, Hart. And I see Emily has a question. Go ahead, Emily.
If we have time. I have many questions because this is such an informative presentation. I'll try to limit myself here. Thank you. First is really about your experience with a primary care spend that's at 15%. And that's, I know that you're still evaluating, and I'm guessing that's very much in progress, but just if you have any early anecdata, even from what it looks like to have the air up there, because we're hovering, I think at what, 4%? So that's kind of question one. Any thoughts on that vision of the future and whether you're seeing outcomes that are different? If you can comment on that. The second question is, any thoughts or experience you may have on implementing the rate caps through the insurers at the same time as the primary care investments were happening? You mentioned that some of that came in the same legislative package. And so I'm wondering if you have any thoughts about what issuers' experience was like having their rates capped on one end, but then also the expectation of primary care increasing at the same time. And if there's a possibility for the third question, this is maybe a question for Matthew, and cut me off if this is too much. I'm curious for any thoughts you may have on the difference between the raise and the and what we have in Washington, which is about 90% penetration of MCOs, from a structural perspective. I noted that you had the shift, have moved towards integrating some things and adding things over time. And so I'm wondering if there's something that's different about the raise compared to a more traditional MCOs. It sounds like maybe some of the care is being reimbursed directly, and possibly a specialty and acute in particular, but any thoughts you may have on that, to the extent we have time. Thank you.
All right, I can tackle the first two, and then I'll turn it over to you, Matt, and I will be brief so that we can try to address all three. Also, you know where to find us, right? You have our email, so we're always happy to continue a conversation even outside of this. I would say, again, around that kind of 15.7, that high figure, look at that across different lines of business, right? And the line that I've been most interested in that our primary care investment target could have actually impacted was that commercial spending. And we've seen that pretty consistently at 8 or 9%. We haven't really seen that move a lot. The other caveat that I would add around kind of the reporting that we do have, as that report has iterated over time, we've made some changes in our methodology. We kind of changed the APM reporting categories. We had initially borrowed from Oregon and then switched to the LAN, and now we're using the common data layout. And so we have seen payers over time, if we've made some of these adjustments, come back and say, hey, actually, we misclassified this spending the year before, right? Like that with this, we counted as primary care and it shouldn't have been. And so we've allowed those types of changes in the past to improve data quality and integrity, but that has made it a little bit harder to actually trace a solid line across what we are seeing there. My suspicion is we haven't actually moved the needle all that much. I think it's looked a little bit differently among different payers. Maybe the 1% wasn't necessarily, maybe we should have, I don't know. There are all kinds of implications around that. So I would say overall, we've improved that reporting every year, right? We have much better data than we did, but I don't know that we're quite there to really be able to make meaningful analysis. And right now we don't really have a capacity or mechanism for tracing out the implications for has that moved patient outcome measures at all. I would say our best data around those kinds of efforts actually comes from the state innovation model, which Rachel, where we actually did have a much more robust evaluation in place when we were working towards some specific goals. In terms of rate caps and how that interplays with an investment target, there weren't actually rate caps as part of the primary care legislation that passed, which puts it has it created a continuous tension, right? We had a bill passed that is increasing spending in one place. In the absence of any sort of capping mechanism or a total cost of care, it's very easy for payers to come back, and they did in the commercial market. Where do you want us to cut spending then, right? So that has been a dynamic that we have seen. Uniquely in Colorado, there was legislation outside of the primary care context around a public option bill that ran. We have our version of a public option, the Colorado option plans. And that did give the division a mechanism to potentially cap prices for, payments between hospitals and providers. So those two have kind of sat together, but they haven't been super intentionally twined. So I think that makes us different. When you look at Rhode Island had a very similar path in terms of an incremental target, but they did have hospital as part of that same thing. And so you can see kind of the importance of having those two components together when you look at some of their results and outcomes. And that hasn't been our case in Colorado. So hopefully that helps clarify. Matt, I'll turn it over to you.
Yeah, and I don't know if you're getting at structural differences between the Rays and the MCOs, but I a couple of things that I can kind of put out there. The first is that our MCOs weren't a matter of choice for the department. They were things that were thrust upon us by the legislature. So the MCO that is operating on our Western Slope has been a pilot program for 8 years. And I'm sort of saying that in a little joking manner. They were like, set up a pilot program and we still have it going. I know they are advocating to push it forward. Anecdotally, we hear from a number of providers and members who have concerns about it. But we also hear from legislators who like the program, want to expand the program. The interesting thing is the MCO is run by the same entity that runs the Ray, which are both owned by United Healthcare. So, they make a case to us that it's saving money, providing better care for the MCO. I would say the data is maybe a little bit mixed on that. The Denver Health one, again, was something that the legislature has required us to do, or at least to offer a contract to them as an MCO. In phase 2, they actually held the behavioral health capitation in their contract. And in phase 3, we just separated that out from them. They had actually been subcontracting it out anyway. Again, we've anecdotally heard challenges from people. And I think the biggest challenges are that on the MCO side, they have much more restrictive networks. So for their pharmacy network, it's much more restrictive. The providers, the PCMPs they're contracting with are a much narrower network than we would have if it were straight fee for service. We don't run into that same sort of challenge as much with our RAIs because they're required to have a statewide network of behavioral health providers. In just a regional network of PCMPs, but we're not precluding all primary care providers from getting paid by the department. So I would say sort of that network stuff is really the biggest challenge that we're encountering with the MCOs. Then the last thing, maybe this is in response to some of the other questions, the real big challenge for us in the state, and Tara, I'm sure would agree with this, is Medicaid's pushing out everything else. We're about a third of the state budget right now and growing. We have some unique challenges in our constitution that limit the amount of revenue that we can retain. And so we really need to get the spend under control. And that happens in behavioral health and that happens in primary care. And I think it's just that's the thing that the legislators are confronting right now. And we're really just throwing everything at it to try to find the solution that works. We're hoping some of these solutions will cut into the problem, but it's the non-ending problem going to be the main focus of our legislative session for sure.
Thanks, Matt. Any other questions from board members? Just want to give, again, just grateful, Colorado. Thank you for being such a good sister state and working with us as partners and for being here to provide the information. So thank you so much for your time. We know it is scarce in terms of fellow public service. So thank you so much.
Thank you. Appreciate
it.
Thank you.
Now I'm going to ask board members to go back to tab 4, the very much anticipated report of the Primary Care Advisory Committee. Dr. Zerzan is here. Judy, we were running a little bit ahead of schedule, so we missed you popping on the call earlier, but you are here as part of the agenda, and we are looking forward to the report on the advisory committee's work.
Excellent. Thank you. Yes, it was fun to listen to some of Colorado's presentation, and I'm here to update you on the primary care spend. I'm going to go pretty quickly, so because there's a lot of words in the handbook, so I hope that you've sort of read tab 4. First, I wanted to let you know we gave some introduction to the committee about the Primary Care Provider Forum. This is a proviso that is in this current budget, which is charged with gathering a group of providers to talk about primary care. I think this nicely complements the Primary Care Spend Committee, and I'm trying to sort of show how they all kind of weave and braid together. Next slide is these are the 3 topics that the Primary Care Forum is tackling over the next couple of years. So the first, quality metric alignment. We have done a lot of work on this, actually. It seems that we have not blown our horn enough about it, but there is a lot of interest in doing that. The second is on primary care spend. And so this forum is next going to meet in September after this primary care spend subcommittee makes its recommendation. So it'll be a nice handoff, I think, to keep moving the work forward. And then the third area is on prior authorization streamlining with some work that's going on. Next slide. The second topic we talked about was a guest presentation from Russ Phillips and Amy Pollock from Harvard. I recommend going to listen to it if you have a chance. Next slide. They talked about an investment guide that they have created to encourage investment in primary care and what they've learned. Next, their methods were both qualitative as well as some rapid literature reviews that they came up with their recommendations, which are on the next slide. There are 5 to match services to strategy and local context, to have sort of hybrid central and local models, doing some investment in workforce, thinking about equity, and then the dollars have to reach frontline primary care. Next slide. So their report has 3 areas that they made recommendations around physician organizations and practices, things payers could do, and things policymakers could do. Next slide. We also had a presentation around the primary care workforce in Washington from the Workforce Training and Education Board. It was really focused on physicians, nurse practitioners, and physician assistants. Next slide. And I'll start with talking about, I'll go over 3 different specialties. This first one is family medicine in the residency match. I think as many of you know, the percentage offered positions in the match has been declining over time, and there are unfilled positions. Next slide. The family medicine physician supply is overall, there is weak student interest and exposure to family medicine, which is seen nationally, but also as seen in the figures here, seen in Washington as well. Next slide. One bright spot is that overall osteopathic medical schools, of which we have one in Yakima, historically have more students entering family medicine. And then next slide, Washington has sought to increase family medicine programs, but those first-year family medicine residents have been shrinking. I think there's more work to do here, especially since earlier this year, there were announcements by 2 hospitals that were cutting family medicine residency programs. And so there's work to do. Next slide, we'll start to talk about internal medicine physician supply. And this is a graph of national data, but I think it seems to be similar in Washington that more internal medicine residents have been subspecializing every year since 2018. Next slide. Another potential bright spot is that pediatric programs are still popular, and the number of folks going into pediatrics is rising. However, I will say there are also specialties that some of these pediatricians go into as well. Next slide. Looking at nurse practitioner supply, this has really surged not only nationally, but also in Washington. This is like a slopey upward curve, which is very exciting. But of note, only about 1/3 are providing primary care according to licensing data. And then next slide, physician assistant, the last sort of cornerstone of primary care. Physician assistant supply has also been steadily rising in Washington, and about 1/5 of those provide primary care in our data. Next slide, there's some recruitment themes, mainly that physicians tend to be more challenging to recruit than advanced practice registered nurses or physician assistants. And then next slide, there's a couple of retention themes. There are kind of a variety of reasons for departures. There's some quotes here about burnout and other opportunities. And then on the next slide, related to burnout, employers report that both patient populations and the work is becoming more challenging, and that makes it harder to keep folks. They ended, next slide, with 5 potential policy actions that the committee is considering. Thinking about payment system reform to improve the daily work experience and administrative burden. Thinking about a compressed medical school cohort plus a primary care residency. There have been a couple of medical schools that have done this. Reconsidering the Washington Student Loan Program. Thinking about how international medical graduates can help, because many of them go into primary care specialties. and then thinking about incentives to maintain and grow family medicine training in particular. Next slide, and actually the one after that. Our final meeting for the year is going to be in August, and we are going to finalize our policy recommendations. This is the process that we're going to do that, and thinking about recommendations in 3 areas, which are on the next slide, that have the takeaways in increasing the primary care spending ratio, thinking about healthcare transaction oversight, and then workforce development. So I suspect we will come back to you in September with some recommendations to consider in these areas. Are there questions or comments?
Thanks, Judy. Questions or comments for Dr. Surzan? Yeah, Eileen?
Judy, I'm quite distressed over the residency program shrinking and to see the data that people aren't even applying. Did you, I mean, in the discussions about that, or do you know what any other states are doing? Because we put money into the damn residency programs and now you can tell I'm just like,
Yes.
I'm speechless.
I share your passion and frustration with that. I think one potential area is while the legislature put money into this, it is part of hospital rates. And so I think it's not totally visible. I think maybe people have forgotten that there's money for some of this. Other states, including Colorado, who just talked about it, do have similar programs that are very focused on specific investment to family medicine residency programs that goes directly to the family medicine folks that do a variety of things working with hospitals. It's set up a little differently than our state, so it's not directly comparable, but there are things that other states have done in this area. And work to be done.
Yep. Thank you. Okay, other questions? Okay. Judy, thank you so much. Oh, Hart. Go ahead, Hart. I see a hand. Don't want to miss it.
No, I was hesitating. I think, I mean, we can support residency programs. If you look at not just the cost of tuition for med school, but housing and everything else, and having a kid that just went through the match process, I got a chance to talk to a lot of friends and what was the view of primary care, family practice. They don't think they can earn enough to pay back pretty significant loans, and there's a cultural challenge as well. So I don't really have a question so much as I think some of the challenges are really pretty obvious and not so easy to solve.
Yeah, it is certainly multifactorial. I will say that Medicare is recommending increasing reimbursement for primary care and decreasing some specialist reimbursement, which might help. But then on the flip side, the federal government has also passed legislation that puts caps on the amount of loans that students can take out, which is $200,000. And I think, as you know, many students, especially that don't come from a privileged background, can struggle to pay for medical school. And so maybe as they talk about that, there could be some changes, but yes, it is certainly a problem.
Great. Appreciate your comment, Hart. Okay, we're going to take a break till 3:45, and we'll convene back here at 3:45, in which we will welcome California as other presenters and move on to, I think, a first recommendation that the board will have for a legislative report later this year. See you back 3:45.
Hi, all. We will be coming back here in just one moment. Thank you.
Yes, all right. One moment, board. Super. Okay, we are back. Welcome back. So now we are going to move on to the topic. So we talked some about primary care and what will be coming at forthcoming meetings with Judy and her leadership. And we'll be talking now about the second topic that has been under discussion with the cost board, which is market consolidation and market oversight. And so we've talked extensively in this particular board forum about some of the particular drivers that lead to consolidation, but also what are some of the ramifications of consolidation on prices competition that exist for both purchasers and patients in the marketplace. So we know that other states, we've already looked at, Oregon's have looked at this particular work to sort of expand or enhance, building on the public comments that we heard earlier from folks, Washington's work in the space. And so today we're fortunate to have our colleague in the state of California who has implemented a program that's been focused on healthcare market site oversight and transaction reviews to help us just continue to sharpen our learning on how other states have approached this, what are some of the lessons and considerations that might be relevant for this state and this particular board. So I think we are having two guests. I want to thank both Brian and Carlia from the California Office of Healthcare Affordability, who are here to present on this topic. So thank you so much for being a good partner and being a good fellow state service to us here in the state of Washington, and we look forward to your content and presentation.
All right, thank you. Hopefully you can all hear me. So I'm Brian Kearns. I'm the Assistant Chief Counsel for the Office of Healthcare Affordability, or OCA as we call it. And I'm joined today by Carlia Suba, who's a lead senior counsel with our team. So what I'm going to do is I'll provide like an overview of OCA, our role in market oversight, the framework that we use to review transactions, a recent expansion of our review authority into private equity hedge funds and MSOs. And we'll end with a brief overview of our online portal for submissions, our team, and transactions reviewed to date. And last slide will just be an overview of lessons learned. So next slide. So OCA was enacted in 2022 in response to the affordability crisis. Governor Newsom proposed the creation of OCA, and it was established within 2022 within the Department of Healthcare Access Information, known as hca. So we have three key roles here identified on the slide. We're attempting to slow healthcare spending growth through spending targets, promoting high value system performance, and reviewing market consolidation. The CalRx program is also housed within OCA, and this is a program that makes pharmaceutical drugs to Californians at a low cost, such as insulin. Next slide. So I think, judging by what I've heard so far, you probably already are aware of how mergers and acquisitions can impact costs. This particular slide is focused on hospital mergers and consolidation. So you see how hospital prices can increase by a substantial amount as a result of mergers and acquisitions. Post-acquisition, you can see prices increase 7 to 9%, 17% at acquired hospitals with an out-of-state purchaser. And one of the key things that we found in reviewing studies in establishing our program is that we see an increase in prices, an increase in cost, but there's really no, from what we can tell, corresponding increase in quality. There's a few that have modest improvement in quality by some measures, but overall we're not seeing a corresponding increase in quality as we are with costs. So next slide, and I think Carly and I are going to kind of switch back and forth here. So she's got this slide.
Yeah, so as of 2018, nearly 95% of metropolitan areas in the United States have highly concentrated hospital markets. In California, most counties are approaching monopoly levels of concentration, especially in our rural areas. And as Brian noted, that highly concentrated hospital markets, there's mixed relationship with quality measures. There are some conditions such as heart attacks where quality tends to suffer. And in this slide, it really highlights the data for mergers in relation to the acquisition of physicians and physician groups. There is an argument that vertical integration especially could reduce administrative costs, streamline care for patients, and reduce unnecessary services. However, the data reflects differently. In healthcare system ownership of physician practices, health prices and spending goes up. There is a higher use of high intensity services, which tend to be more expensive. In private equity ownership, they also have higher prices and increased utilization of high cost services. And as we mentioned previously, there's mixed quality measures, so some good, a lot of bad quality measures. And then also there's reported lower patient experiences. And as you can see on this slide on the right side, that graph shows that in recent years, there is a reduction in independent practices of physicians. And inversely, there's a rise in corporate ownership and private equity ownership and health system ownership of physicians and physician groups. Next slide. So the California legislature created OCA to fill existing gaps in our healthcare market oversight. OCA's role is to provide transparency and gather insight in our healthcare market that was previously opaque or sometimes completely unavailable to the public. So OCA supports the Attorney General's office and our sister departments, the Department of Managed Healthcare and the Department of Insurance, in analyzing the impact of costs for our consumers, as well as access to care and quality of care. Part of that is that we seek input from these parties as well as the public on the anticipated impacts to our healthcare market. We also collect and report information to the public, and we publish that online on our website. And for transactions that may reduce market competition or increase costs, we refer those transactions to the Attorney General for further review, and then they can choose whether to challenge those transactions. Next slide.
All right, so OCA has an enabling statute that goes along the lines of what Carly was just talking about. Our role is to really monitor cost trends and to conduct research and studies and review transactions that impact market consolidation. As we further specify in our regulations, in order for us to commence our review, healthcare entities must submit what we call a material change notice to us, or MCN. And this is for transactions involving a material transfer of assets or control to another entity. Per our statute, notice is required at least 90 days in advance of closing. Next slide. So who are we getting notices from? Well, this slide outlines the healthcare entities that are identified in our statute and regulations. So we're looking at payers, insurers, providers, hospital, pharmacy benefit managers, parents, affiliates, and subsidiaries acting as an agent of a payer. And I think this probably gets more to the lessons learned. Healthcare entities that are a party to the transaction or a subject of a transaction must file. So the subject of transaction language was particularly important for us because when we first launched our program, we noticed that entities were forming corporate entities to essentially conduct the transaction. And that was whether intentionally or not, it was a way of kind of circumventing our noticing requirements. So we crafted our regulations such that when a healthcare entity like a hospital is the subject of the transaction, and they may not be a transacting party necessarily, we still have to get notices of those transactions. All right, next slide. You're up, Carlia.
Yep. So this slide is an overview of what our review looks like and the timeline of it. So our review process begins when the healthcare entity provides their MCN to OCA. And as Brian mentioned in the previous slide, that they are required to submit notices to us 90 days before the transaction is scheduled to close. Once we have all the required information in the material change notice, that's when we begin our preliminary review of the notices to make a determination of whether we will require a cost and market impact review or CMIR. If we decide that the transaction must undergo a CMIR, we will notify those. If we decide that they do not have to undergo a CMIR, OCA will notify the entities within 45 days. However, if we do decide that they have to continue on with a CMIR, then we notify them within 60 days. And then these timeframes can be extended if OCA requires additional information from the parties, or if the transaction is being reviewed by another agency whose decision may impact OCA's decision. So then if OCA decides the transaction needs to go to a CMIR, parties have 10 days to request a redetermination review, and then our director then has 5 days to respond, and we can add an additional 5 days if required. Once a CMIR has started, we have 90 days to complete the CMIR with an option to extend an additional 30 days if we need it, or if we require additional information from the parties, we can toll that timeline. So as you can tell, that's a pretty short time frame to get information, analyze it, and create a report. So once a CMIR is completed, we issue a preliminary report and give the parties and the public the opportunity to submit written comments. Once that's done, we issue and publish our final report online. Next slide. Brian?
All right, so Carlia has described kind of a two-tier review that our team undertakes with each notice. So the first step is really to determine whether we're going to conduct a CMIR on the transaction. And with the initial 45-day review and with the cost and market impact review, we work with economic experts to help us understand the market impact of the transaction and how it may impact cost, quality, access, and the labor market, along with equity. So this slide and the next couple of slides broadly just identify the factors we consider. So for this slide here, these 5 factors and the next slide has factors too. These are what we consider during our 45-day review. We're looking at, based on what has been provided to us in the notice, is there a chance this transaction results in a negative impact on access? Will it have a negative impact on costs? Is it possible the transaction lessens competition in the market or for workers? Will it directly affect a general acute care or specialty hospital? Next slide, please. Quality of care, a big consideration. Or do we have any indication that this transaction is going to impact the delivery of care, the quality of care? And then the next 3 kind of focus on, is this transaction part of a series of transactions by the acquiring entity? Are we seeing one entity kind of entrench themselves into a particular market? Is there an out-of-state entity involved that's acquiring an in-state healthcare entity, and that may have corresponding impacts? So we're looking at all of these factors to figure out what is this transaction, what might this transaction do? So next slide. So if we decide that one or more of those factors, let's say that this transaction poses a legitimate threat to quality and market competition, that's when we would determine that a CMIR is required. And during the CMYR, we're going to look at a lot of the same factors. We're going to take a much deeper dive into how that transaction impacts quality, what the history between the acquiring we'll look at how the acquiring entities, their previous transaction and the history there, what trends have we seen, the quality, access, and market competition trends. We'll take a really strong look at the market competition component in both tiers of the review, especially considering when you consider how market competition can really have corresponding impacts to cost, quality, and access. We really take a hyper intense focus on how this transaction is potentially going to impact the particular market. Next slide, please. So yeah, these are some of the other factors too. An important part, this is important as well with the 45-day review, but it's also built into the CMYR process, is there's a real engagement with the public. So we like to get whatever concerns are by the consumers, the patients, providers, unions, or whatever. They have the opportunity to really tell us how this transaction may impact them. And that's we can get that during the 45-day review, but it's really built into the CMYR, and those concerns will be considered, and we may share them in the final report if they're not confidential. So next slide.
Okay. So there sometimes can be confusion on what OCA's role is in reviewing our market consolidation. So we do not have the authority to block or approve mergers, but we can refer transaction to the AG's office, and they can conduct further analysis or challenge a transaction under state or federal law. What we do is we review proposed mergers and acquisitions involving healthcare entities. If appropriate, we conduct CMYRs when a transaction is likely to affect competition or affordability or the ability to meet cost targets. And we also work with state and federal departments to share information and coordinate on oversight. And you can probably tell or already know, but this is really important because healthcare mergers can increase costs to patients who are the direct consumers, employers who provide employee health plans, and then taxpayers who support public health insurance programs. Gathering, analyzing, and publishing information from our MCNs and our CMYRs informs policymakers so that they then can better address affordability and the effects of consolidation. Next slide. So in October of last year, AB 1415 was signed into California law. Previously, only healthcare entities were required to submit notices to OCA. And as Brian mentioned in a previous slide, healthcare entities consist of payers, providers, hospitals, PBMs, or parents, affiliates, or subsidiaries acting on behalf of payers. So after reviewing transactions for over a year, what we noticed was that healthcare entities are only a limited portion of who are involved in these types of transactions. So AB 1415 expands our insight on the involvement of other entities to these transactions, and they include private equity, hedge funds, management service organizations known as MSOs, new entities created for the transactions, and entities that control providers. Next slide. So OCA is in the process of updating our regulations to comply with AB 1415, and this includes updating our definitions such as noticing entities, MSOs, hedge funds, private equity. Our updated regulations will clarify who must file a notice. For example, what type of MSOs qualify as a noticing entity. So for example, on the slide, it says an MSO owned by a hospital with 2 or more providers as clients would be a noticing entity, or an MSO affiliated with a health plan and a hospital could be a noticing entity. And then our updated regulations also clarify what types of transactions that require noticing entities to file notice with us. These are consistent with the types of transactions currently required by healthcare entities to file. But an example of this on the slide is a private equity group that acquires assets of a healthcare entity and the ability to appoint leadership. That private equity group would then be a noticing entity required to file notice with OCA. Next slide.
All right, so when we were first launching our program, we were simultaneously drafting regulations to implement the enabling statute, and we were also establishing an online portal. So what this portal does is, healthcare entities will go to our portal and they'll be asked a series of questions about their transaction, and they will also have the opportunity to they also will provide us with the required documents. So this is a screenshot of the first page of that portal. If you're a healthcare entity, you log on, you create a profile, and you say, I want to submit a notice to OCA. This is the first screen you'll see. They'll ask you some kind of threshold questions to determine whether your transaction meets the requirements of our statute. And then if you say yes to a few of them, you'll proceed forward and provide us with all the required information and documents. I think this portal, it was kind of a heavy lift at first, and it remains a semi-heavy lift, but it's been incredibly helpful to us. Otherwise, the only other way we'd be getting notices is by emails with attachments, and I think that would just not be workable considering the volume of documents and information we can get. All right, next slide. So this is the general structure of our team. We have an assistant deputy director and then 2 assistant chief counsels, me being one of them, and we manage a team of attorneys that review the MCNs, conduct CMIRs, we manage other investigations, and we support other OCA programs. The 2 assistant chief counsels have their own teams of attorneys, and when you're assigned, if you're an attorney, you're assigned to a transaction, there's a corresponding attorney who's firewalled because we have an appeal process. So once we decide a CMIR is required, we have a separate attorney assigned to the appeal, just to make sure it's fair and equitable to the appellant. We currently have 6 attorneys and 1 analyst, but we're resourced to expand over time. And as I mentioned previously, we do contract with a number of economic experts who assist with our transaction reviews and other investigations as needed. Next slide. So here's an overview of the transactions we've reviewed to date. We have 49 transactions filed from April 2024 to June 2026. We had a lot of pre-filing meetings that first year and the second year, and these pre-filing meetings are really important. We have law firms mostly represent the healthcare entities that are filing these transactions. They often reach out to us just to kind of give us an overview and ask us questions. And these meetings are just really helpful because we can get ahead of any issues that they may have. And each transaction might have multiple notices attached to them, or they might just have one. Okay, next slide. Here's some kind of, oh wait, this is you. Sorry, Carly, go ahead.
No worries. So this slide shows the types of transactions that we have reviewed. You may notice that the total in this slide says 52, whereas in the previous slide that Brian went over was, I believe it was 49 types of transactions. And I think that's because there are some transactions that involve different types of healthcare entities. So a skilled nursing facility, perhaps, and a hospital. As you can see, our most common...
Brian and Curly, there's a clarifying question on the slide, on these couple slides. I just want to make sure Leah had opportunity to ask. Leah?
Yeah, go for it.
Oh, sure. Thank you. This is really good information. Really appreciate it. By type of transaction, I'm assuming that means that's the acquired entity or entity type?
That's generally how we're classifying them. It doesn't always neatly fit into that kind of category. So if there's like a merger between 2 providers, we might just call that like a provider acquisition.
Yep, that makes sense. And then can you give an example of what would be in the others category? It's about 15% of your filings.
Yeah, so what we've categorized in the others are federally qualified health centers, IPAs, holding companies, and health systems.
Okay, that's helpful. Thank you.
Yeah, you're welcome. Yeah, so that is just kind of a nice overview of the types of transactions we have reviewed to date. Next slide.
So here are some lessons learned. I mentioned the first one when we first started our program. It just became very apparent to us the various ways in which these transactions can be structured. So if you're starting a program and your requirements are that if a healthcare entity is involved in a transaction or a party to a transaction, you just need to be very mindful with how those transactions can be structured, because if they're using corporate entities, that may fly under the radar of your regulations and statute, just depending on how it's written. So it's also important if and when you do launch a program, you just need to be you need to monitor the market to the extent you can to figure out what transactions you aren't seeing that you otherwise should be seeing under the statute. And Carla, you have two.
Yep. So ownership is opaque. So what we've learned after reviewing our so many transactions is that ownership structures can be convoluted and involve various types of entities. Hopefully with AB 1415 and updated regulations, we hope that that helps provide better insight into healthcare entity ownership and then the different reaches of ownership in the healthcare market. Brian?
Yeah, so the timelines for your review can be very challenging. I think that mostly for the 45-day review, we're mostly okay, and that's usually a sufficient amount of time for us. But a 45-day review, practically speaking, that means that we work with our experts for the first 25 to 30 days. And then, like any other state agency, we have to offer a recommendation to other folks within our department and maybe people outside of our department. So there's an approval process that we have to be mindful of as well. For a cost and market impact review, our regulations set a 90-day review timeline with an optional 30-day extension, and that is a very challenging timeline to meet unless you're pausing the timer, which we generally try to avoid unless absolutely necessary. So doing a very comprehensive review in 90 days is challenging on a number of fronts. In that time, you have to get data from the parties, potentially third parties, other state agencies, and you may not be able to do your analysis until you get that data. And we really do try to keep things moving so we don't have to pause the timer because the parties can't close their transaction until we complete the review. So it really does put a lot of pressure on our team. And I see we have a question.
Oh, thank you. Yes. My question is, I don't think you mentioned whether there is involvement from sort of I guess you'd say subject matter kind of expertise perspective from medical professionals. Are there healthcare or medical folks included at any step along this way?
It would depend on the transaction. To date, I don't think we've involved medical professionals directly. We have coordinated with other departments that oversee medical professionals, but I don't think we've necessarily involved them. I guess it would depend on the transaction. We're always looking for additional input and sources of information whenever we're reviewing a transaction, so we certainly could make that inquiry.
Yeah, I think that kind of input could come to you through your open, kind of process.
Right.
But that would be different than sort of baking it in, even if it were not always included, if there was a trigger of some kind, which you kind of suggested, maybe there would be a trigger. I'm thinking about, issues of access and quality. That I understand these transactions are in many cases large business transactions, and they're with lots of legalities and everything. But of course, what we're really trying to do is to understand, impacts on actual quality of care and access. And so it can be that people who are very close to the impacts, have a perspective or have insight about how something impact that may occur that wouldn't necessarily be noticed, or not that you're not being thorough. But anyway, yeah, just kind of wondering about that. I don't have any specific example of what would be at risk, but something that came to mind. Thank you.
Yeah, very helpful. It's something that we really wish we had a little bit more of is just engagement from the public when we're reviewing transactions. We have a website. We make ourselves available to any providers or patients or consumers who may be impacted by the transaction. We have regular board meetings like you all do, and we present transactions and to the board, and public can engage there. We have an advisory committee involved with various stakeholders in the healthcare market. So we certainly do invite any kind of input we can get from affected providers and consumers. It just hasn't been there yet. Carlia, are you on the?
Yeah. So Brian touched on this a little bit when discussing our timeframes, but another lesson that we've learned is that to fully analyze the impacts of a transaction, notices must provide sufficient information and documentation for us to do a thorough analysis. And early identification of missing information and communication with submitters is really important, so that we can get any missing information early and provide our experts and ourselves the time to do an analysis, especially given our tight deadlines. Brian?
Yeah, and the last thing here, it's come up a few times. We try not to do this, but it is vital to have the ability to pause a review. There are times when we've been in the middle of a 45-day review and we discover some data that is needed, or we need to reach out to another state agency to get their input, and that can take time. So having the ability to pause the review can really make for a more robust analysis of the transaction. And I think we have one more slide. So yeah, we completed our first CMIR in April, and there's a link to our final report and supporting documents. This is separate from the CMIR program, but OCA also conducted a study of hospital market competition in Monterey County, and our team was really involved in that. After a couple of months of getting the same questions over and over again, we decided to create an FAQs about our CMIR program, and that's been tremendously helpful to the public. We have a list of all of the transactions that have been reviewed and are currently under review. And for any questions or comments from the public, we have an inbox that's regularly monitored. And I think that's it. So any other questions you might have?
Brian, thank you. And Carlia, thank you so much for the great overview. And I think, just sitting here reflecting, I see a lot of similarities to what we saw from the state of Oregon, and appreciate your lessons learned. And as I imagine, if we are as a state are on this journey, your FAQ will be helpful for us of how to even frame that in the future. So just thanks for the good content. Are there questions from the board for our presenters today? Great. Hearing no questions, Brian, or additional questions, since we took questions throughout. Brian and Curly, thank you so much. Again, we really appreciate your time. We know it's scarce as public servants, and we're just grateful. So thank you for being here today.
Thank you.
You're welcome.
Okay, I think we are going to move on to part of the conversation right now where we really want to have some strong board engagement that would potentially tee up some or vote on potential recommendations as we sort of march towards opportunities of putting our legislative report together. So we've been on the journey over the course of the past few months of looking at each of these three areas, and I would say in the market oversight transaction area, I've heard a number of a couple of other states who are doing that. And I think it's important, we obviously heard public comment on this, just to acknowledge that I don't think it's in the intention of any of the board or the board's member of this particular review of the topic that market consolidation or market considerations and dynamics that we've been discussing are inherently bad. I don't think that's a position we necessarily come for. It's just to understand sort of what are the overall larger ripple effects and implications on communities that the state serves of access, quality, and affordability. The other thing that I appreciate deeply from what we also heard in public comment was that market consolidation and oversight, of course, doesn't necessarily, even if states have those tools into place, doesn't necessarily look at the overall drivers that's sort of leading to those things. But I think as we've also talked about as a board, that, and what we've learned from other states, is that because you have a process of oversight, you actually do get insight to what some of the drivers are that are leading to this work, that then can catalyze or accelerate other policy opportunities that drive sort of the costs of other considerations of why these dynamics might be happening. So I very much view that conversation and dialogue as a both and I know from many of the comments from the board over the last few months, many of you share that perspective as well. So I think the goal is I'm going to hand it over to Jen and Ross to give us a presentation on sort of the next steps or how the board would approach this from a recommendations perspective. And then I think we'll have a dialogue and a discussion on a potential vote and then what comes next as we march towards the biennium. So Ross and Jen, I will turn it to both of you to facilitate the next part of this.
Thank you, Ryan. And Jen and I are going to do a quick overview of some of the topics that we've talked about so far and hopefully leave most of the time for discussion. So I'll throw it to you, Jen, to start us off.
Thanks, Ross. Next slide, please. This is just here as a reminder that focusing on in the increasingly consolidated healthcare market and potential market transparency and oversight mechanisms is one of the three primary areas of focus that the board has been looking into this year. And then as highlighted, we've been particularly focusing on transaction review over the past few meetings. Next slide, please. This graphic shows all of the cost board and advisory committee meetings that have occurred this year. So today is the fourth time that the board is discussing market oversight in 2026. And additionally, all of the three advisory committees have had in-depth discussions and presentations on the topic and have also made recommendations to the cost board, which we'll summarize today. Next slide, please. So today, the goal is to discuss and vote on recommendations regarding market oversight for healthcare consolidation, which will be included in the 2026 Cost Board Legislative Report. Next slide, please. Just a quick review of some consolidation trends. Washington, as we've heard in other presentations this year, Washington has moderately to highly consolidated markets, healthcare markets. Insurers are purchasing physician practices, pharmacy benefit managers, and healthcare benefit managers. Hospital consolidation with health systems has increased 18% over the past 25 years. And today, 54% of Washington hospitals are affiliated with multi-hospital systems. And we have also seen the growth of private equity over the past decade. Next slide, please. As Director Moran mentioned, concerns about consolidation need to be balanced against the potential benefits of consolidation and the fiscal realities of healthcare organizations and entities. For example, some mergers occur to support struggling facilities or healthcare organizations, such as rural hospitals. On the other side of the scale, concerns include multiple risks that are often experienced in consolidated markets, which were well described by our colleagues from California. These include higher prices and referrals to higher care settings, changed financial incentives for those working in consolidated systems, reduced access, quality, and choice, and the risk of financial instability. Market oversight tools are designed to try to bring balance to markets. And with that, I will turn the presentation over to Ross.
Thank you, Jen. And I'm going to pick up here. Again, this is intended to be kind of a high-level visual aid to help us understand differences between peer states that have more robust market oversight frameworks in Washington. If you recall earlier during the public comment period, Wisha very helpfully noted, we did have an error here. That second bullet point speaking about our current material change transaction notice review, it says that the review is conducted post-transaction. In fact, that is conducted pre-transaction. Entities, healthcare entities that are subject to the notice of material change transaction law need to provide that notice 60 days in advance of the transaction closing. So I apologize sincerely. That's my responsibility to make sure that these don't have those errors. I believe this is the fourth time that we've discussed this topic, and I think we've got it right in the 3 previous times, but do want to acknowledge that
You're doing great, Ross. I'm just going to tell you that. You're
well,
doing great.
I appreciate that. It's the errors that stick with you, and so I will remember this.
And it's the learning that happens with them. So
Yes.
you're doing great.
Yes. Okay. Thank you. And so with that, though, the kind of point of this slide is, again, to identify that some of our peer states like Oregon and California have more robust transaction oversight laws. Again, Oregon, they can actually deny a transaction, as we just heard from California. They can refer it to their AG's office for consideration of approval denial, but they can issue a CMIR if they deem that appropriate. Next slide, please. So I wanted to kind of, as we're heading into recommendations, try and provide an illustration of a transaction that happened here on the West Coast, going back to 2016 with Providence Health and Services merging with St. Joe's, and just kind of showing how transaction review looks different on different states that have different levels of oversight. Just quickly, in Oregon, they were able to conduct a pre-merger review. They ultimately decided not to conduct a more broad public hearing and full comprehensive review, but they were able to place conditions on the transaction, and I listed a few here: maintaining reproductive and women's health, preserving specific services in Oregon for X number of years, so that residents could be assured that post-transaction they wouldn't lose service or access to facilities. So just documenting that. California did conduct a full comprehensive review and were able to place conditions similar to what we heard from with Oregon, with being able to say that certain services need to be maintained for a number of years. There was also specific charity care obligations that were maintained, 8 public meetings. So not only was there transaction review, I think there was quite a bit of public engagement that was able to happen around this transaction. Washington, again, we do not have any type of transaction review. We receive notice of a material change transaction, but that is the extent of the material change transaction review. Again, we've covered this in previous meetings. We have other forms of or other opportunities to review transactions, such as our antitrust laws or consumer protection, but those are getting at different issues, not necessarily access, quality, costs related to the healthcare system that we're focusing here on related to transaction review.
And Ross, can I ask a quick question clarifying on this?
Yes.
This I know one of the public comments was some of those tools that you're discussing about weren't readily available at Washington at the time.
Yes.
Those did not exist. However, I think what this is illuminating is that the other 2 states that had these particular reviews did have at least some of these guards in place at the time where we did not. They, of course, have advanced since then, Oregon and California, even more so, right? So I think what this also illustrates, we may start at a different place, even from 2016 as an illustrative example.
Thank you so much, Ryan. Yes, that is exactly the point. I could go back and look at the exact year the material change transaction law was passed, but to your point, Ryan, yes, the other states had more robust at that time and continue to have more robust transaction review. But I think another important point to say is, even today, with our material change transaction law, we would still not conduct a review. We simply get notice of the transaction and hopefully bring public attention to it, but there is no review of access or costs or those types of things. So So
That's
yes.
very helpful. Very helpful. I just want to make sure that was
Thank you.
clear for everyone.
Yes. I'm not going to cover it at length here, but do want to just note in the appendix, we included another summary. I believe it starts on slide 115 of a transaction that occurred in 2016 in Kitsap County between CHI Franciscan and acquiring West Sound Orthopedics and affiliating with the Doctors Clinic, and kind of giving the overview of sort of the ramifications that happened as a result of that transaction, with the Attorney General's office ultimately bringing a federal antitrust lawsuit alleging price fixing and restraining competition in Kitsap. That transaction ultimately was resolved via a settlement agreement with the Attorney General's office, and hopefully there's a helpful summary of that along with sources in the appendix. But I think that's an illustrative example of what happens if you don't have a transaction review program. You're left to try and resolve those issues post-transaction when there's the potential for harm, loss of access, and cost increases. So hope folks can review that. And next slide, please, Audrey. Again, we can go through this quickly, but this is some highlights that we've heard throughout our meetings related to market oversight and transaction review about some of the impacts, contributing factors, and mitigating actions that we can take related to consolidation in the healthcare market. I'd just focus for one moment on the contributing factors, as I think this is a source or issue folks would like to investigate a little bit more. So we do have some information that we've learned from the meetings here, but acknowledge that we need to spend some more time perhaps identifying some of those root causes. If we go the next slide, Audrey. This is an attempt to try and make sure that we're accounting for past recommendations that the cost board has made, and is kind of the reason that we've gotten to this point. In prior years, the cost board had articulated that they would like to look at these 4 or 5 different recommendation topics. And so this was our attempt, kind of the transaction review, market oversight, to touch on most of these. And so, again, hoping that these past few months, and I think as Jen noted, 4 meetings that we've discussed this have hopefully, touched on these topics that you noted you'd like to hear more about, and hopefully hearing more about corporate practice and medicine specifically next year. So if you go the next slide, please, Audrey. I'm going to apologize again because this says after transaction review again for Washington. It should say pre-transaction review, but the point being that there's not the ability to deny or conduct a cost and market impact review here in Washington. We're simply being provided notice, as opposed to California, Massachusetts, or Oregon and New Mexico that have more robust transaction review levers that they can use if after review there are concerns that they have regarding the transaction. So again, we will amend these and amend the packet post-meeting, and my sincere apologies. Next slide, please, Audrey. And so this is our potential recommendation, and I'll give it back to Ryan to discuss this. But again, we hope that the prior meetings and discussions about this topic, we hope that this is kind of where we're leading, but are looking forward to the discussion today about this.
Sure. Thank you, Ross. Appreciate that. So I think at the moment we'll facilitate some discussion amongst the board. This is, I think the recommendation is moving us in a direction of, given what we know, given what other states have, or what we have learned, that there should be a recommendation to pursue healthcare transaction review programs that look at some of these particular pieces. And I think, in consideration of this particular recommendation, the agency would leverage and utilize what we've learned from other states as well in that report to sort of assess sort of like what the opportunities are. I'm sure folks, when you read this, will say, as we think about putting this forward as a policy recommendation, that sounds great. What comes next in terms of that? Because there's a lot of sort of implementation details to figure out. And I think in a couple of different ways, one, I'll just sort of address that directly head on, before we start this discussion and proposal, is to say, this could become continued extension of the works of the board's work in 2027 as we engage with the legislature for 2026 to get, very serious about the details of what that would mean. Or could it look towards sort of providing the examples from the other states and allowing the legislative process in 2026 to play out on itself? But we obviously know that in either of those scenarios, there's a ton of details to figure out. But I think the direction that this board has been working on is to move in a direction where there's more thoughtful oversight over review of these particular programs in the future and to make that known as the legislature convenes in 26. So that is maybe I'll pause there and see if there are discussion, agreement, thoughts, comments from the board. Next slide. Eileen?
Well, I just have one question on how that's phrased, and for the motion is, it doesn't make it clear that we would like the review prior to merger. Like it's because we would hope that at some point we're going to move towards whether we approve mergers or not. And if you don't get all of this information prior to the merger, it's hard to close the barn door after the cattle are out.
As a beef cattle farmer, I appreciate that reference, Eileen. So I think that's a good feedback, good comment. Yeah, Emily?
Thanks. Well, appreciate Eileen's comment, and I think would add the concept of post as well, because prior is important, and then as we've heard from the other states, some ongoing monitoring is important as well. So
yeah, especially definitely heard that from Oregon.
Yeah. So I think that just in terms of the recommendation as it's written, full support, no concerns with the recommendation. These are pieces that could either be added into the language for the vote or highlighted in discussion in the paper. I think a couple other pieces that are on my mind. I see this recommendation as necessary but not sufficient, which is we should have done this in 2020. We should have done it in 2021, 2022, 23, 24, 25, any of the years that we've discussed this. And we did just recently make a step forward in the legislature, but it's not too late, but time has marched by and the affordability issues have worsened. So we've been at this board since 2020. Where we are right now, we've seen survey data that 2 in 3 Washingtonians skipped care they needed last year due to cost. We have heard that according to Gallup polling, healthcare cost is Americans' #1 economic concern. We've seen recent surveys from KFF that says that healthcare cost is Americans' #1 healthcare concern. We know that this is the 5th year of significant premium increases that are in the double-digit range for individual small groups. I assume large groups if we had that data. And we have not bent the cost curve in this body, which is what we're supposed to be doing. We have not aligned with the benchmark. And HR1 will make all that worse, right? So I think I would say let's support this recommendation, and then let's also work aggressively at some of the other strategies around limiting price growth in a broader fashion. One other thing that I'll just mention around maybe detail that could come in the recommendation section is I think it's important. We've learned from the other states that you need to look at a full range of healthcare entities and configurations in this review program. When OIC did their analysis, they showed, and we heard this again from our California colleagues, that many of the transitions are not limited to traditional hospitals, provider organizations, but are increasingly in some of the lesser known transaction spaces, so skilled nursing facilities, labs. We have no data or insight into that whatsoever in Washington. And in fact, as we noted when we looked at the health entity registry bill, there is, in some cases, we don't even know what the entities are. So I think that's important to kind of keep in mind. And again, doesn't need to go in the recommendation, but is perhaps something to continue to note in the discussion. Last piece is I did hear from our colleagues at WSHA and WSMA about continuing to look into state data on this topic, continuing to look into underlying drivers of consolidation. And I think those are fair points and important points that should be, again, raised up in the discussion as ongoing work.
Emily, thank you so much for your thoughtful comments as always. I want to also maybe go to the next slide because we're looking at the proposed recommendation. And to get to Emily's point, folks can go to the next slide. Yeah. Oh, there we go. So we have a little start on the slide. It's just, I think to Emily, your point, we want to tee this up. This is a broad recommendation for today, but through sort of a white paper or other opportunities for the board to be reviewing sort of the proposal as we send to draft to the legislative consideration. We welcome and invite sort of board perspective on that in terms of what detail that the board is willing to be involved in developing sort of the proposal that would get to some of the details, because I think those are all very, very important that we want to make. Plus, we want to make sure that the top line, to Eileen's point and others, that the language of that is strong and sufficient that then leads towards the rest of that as well. So just wanted to mention that. But thank you, Emily, for your comments. Maybe I will turn, we had online Hart first and then Leah. Hart.
Yeah, I actually dropped my hand because part of my comment or question was, are we looking at just a very simple recommendation today to develop some type of a review process, not approving any of the details of the process?
Right.
And I think that's true. Another thing I was going to mention was the need for data, and that was just highlighted. And as we think about the review process, I would want there to be enough of some back testing and ex post review so that we learn and let the process evolve.
Yeah. Great. Thank you, Hart. And I think the answer to the first question would be yes. Sort of, I think I would pose today's conversation of the recommendation as directional to move in this direction as recommendation to the board. And then as the staff and agency move into the details of what the board has reviewed in the past 4 meetings, we'll get into some of the details of that board report. Leah?
Thank you. And thanks to the staff for the presentation. It was very helpful. And to other states that were willing to share their experiences, I think that'll all be very useful for us as we proceed. And I would support as well, maybe just a +1 on Emily's comments as well about, I appreciate the reminder that we have multiple strategies we're working on and we're focused on one today, and it is important. And we need to make progress on the broader goal. What I was going to say about this one, just as there might be other guiding principles. So I heard kind of one from Eileen, another might be, but just open for more discussion. I heard earlier there are certain review processes, which I think we've heard from our earlier reporting in the year, and just maybe some clarity on intent that this is not meant to duplicate where there are already functional components, but is meant to add on because we don't have the robustness that, and there are gaps in it. And that's what this is intended to fill. And I'm just putting it out there because maybe people did have a different view, but that was where I thought we were intending on heading.
Yeah, I completely agree. And I think that's the intention of the board too. And I think it's a good comment. Again, appreciate the folks who provided public comment to remind us of what we currently have at the state, but also in the process, I think the board has identified, much to Emily's comments, too, opportunities, right? And with other states of where those gaps might be that would give us additional levers and insights. And again, I think you can come at this conversation as sort of this body, if you will, sort of being adversarial to these kind of discussions or conversations. I don't think that's the intent of all of this particular body, but it is to say, one, let's have an oversight and overview of what's happening in the market. And two, I appreciate the post-review comments from both Emily and Hart, because that will allow this body to review other things that might be driving up costs in the future too, that we don't have full insight into today, and would welcome partners who offer those comments sort of the open-mindedness space to think about that as an opportunity too. Other comments from the board? Eileen, are you off mute?
No, I guess I am. I'm sorry.
Okay. Anything else to say, Eileen? No. Kim? Kim.
Well, I have a question. I support I think the white paper level of involvement would be, it resonates with me. So I'll just answer the question on this slide in that way. I guess it's the middle of the road opportunity here. The question I had is, been really chewing on the comments from public comments, and then Ryan, your acknowledgement of, yes, it's important to understand the drivers, the backdrop, the why we can see what's happening, why why is it happening, and then is it our intention that the transaction review program would be sort of strictly construed as reviewing the transaction that's proposed for impacts? Or is there actually a piece of greater understanding and analysis of the situation, of what is actually happening in a community or happening in a region that is setting the table for, or creating this sort of there's the reason for the transaction. So I guess and I don't know that I have a strong, I'm going back and forth with myself. I've been having an argument this whole meeting about whether we should be a little more explicit about this analysis understanding aspect of the transaction, or whether the mention of transaction review for impacts on access, quality, et cetera, suffices. So I've been thinking, don't need to say that, Kim, and then, oh, well, maybe you should. So I've been going back and forth because I'm not sure what's in the minds of each of us. So I'm sort of lobbing this out there to maybe seek clarification and elicit, is it the role of transaction review program to understand and to analyze, or is the understanding analysis of the drivers and what's leading up to this, these activities, is that actually work that really doesn't belong in the transaction review program? Maybe that really is more connected to our work on drivers, on cost drivers. And so anyway, I'm just curious what the other board members are assuming, and kind of how you see where would we place that work, that understanding and analysis work that's been suggested to us. So yeah, that's my question.
Yeah, thank you, Kim. I'm glad you listened to the inner Kim to lob it out there and put it on the table. So invite that always. Maybe I'll take a stab at it, and if others want to comment, I think it's a both and, because I think that the transaction review process up front, if we solely come at this from a cost perspective, then we lose sort of the value of sort of the other elements of access and affordability and equity, of why these things might have to happen for local communities to be able to receive services, et cetera. So I think, one, it's about understanding sort of the bigger, broader picture of what is the transaction actually doing as it relates to the overall depiction of cost, but then assessing sort of some of these other drivers that gives the states an obligation to say yes or no to that based on a multitude of different factors, rather than just surveying it around one specific one. So I think it's both, and then the portion of that particular review, which I think other states have alluded and spoke to well, of sort of documenting sort of that big part of review, having consumers be involved, having sort of broader public engagement so that there's full knowledge and scope of what's actually happening, then gives further data for a body like this or the state to act in other ways of some of those things, some of those learnings in communities, particularly as they are assessed to be more systematic, that could be supportive of statewide policy, but I don't know how others feel. Go ahead, Emily.
I agree with that, and I appreciate the point, Kim. And I'll say this: when I look at the other states that have done this, I see the states that are working most effectively are doing that parallel work of they're looking at the individual transactions. They're also doing overarching market analysis. I think there's actually a piece missing from the states that are currently working on this today, which is what is the alternative or collaborative policy discussion that you can have with an entity that is in a difficult transaction situation to help them towards a different outcome. And here I'm playing against type as a lawyer because I understand it's kind of approached as a regulatory consideration. Yes, no, or with conditions. But I think the states that have done this so far have not answered a reasonable question, which is, what else are we supposed to do? And I do think if Washington walks down this path, I would like to see us have that conversation with health entities about, in some cases, there are reasons that maybe are not so great for the transaction. In some cases, there are factors that are really important that are, if this particular transaction is not necessarily going to be in the public interest, what else are those entities supposed to do or a community supposed to do? So I do see that as part of our, I guess, my personal view of this recommendation.
Great. Being sensitive of time and also having a robust conversation, maybe ask so we can have our staff work on sort of a draft developing of here for consideration for this board's review for formal adoption of the resolution. Maybe I'll just note, the formal one that's here is, the board is adopting that we would pursue pre-post and ongoing healthcare transaction review program, if you will, that allows for meaningful review of the transaction's impact on affordability, access, and quality, denoting there'll be much more that be coming as part of the substance in that particular report.
Yeah, and I'll just add, excuse me, we're planning on in the September meeting of bringing some concepts for topics that we'd be reviewing in 2027 with some potential ideas about ways that we could continue the transaction review discussion, but just wanted to hear folks' feedback on that second question today. So this is really sort of a two-part. This would be what we'd be including in our legislative report this year, and then coming back in September and seeing how, based upon the conversation today, we'd like to proceed with continued discussion of transaction review if there is an appetite for further dialogue on that.
And Ross, just noting that you plan to have this discussion at the August stakeholder committee as well to make sure that our healthcare stakeholders have an opportunity for input and helping to shape that conversation that comes to the board in September before you finalize your legislative report.
So more voices part of the process. That's great. Thanks, Michelle. Okay, maybe I'll call as chair, is there a motion to adopt the market oversight recommendation for inclusion in the 2026 legislative report?
So moved.
Motion on the table to adopt the recommendation. Is there a second?
Second.
I'm sorry, who did the second?
Lois Cook.
Lois, thank you, Lois.
Mm-hmm.
All in favor from the board, say aye.
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 Are there any opposed? Hearing no opposition, the motion for this to move forward as a legislative recommendation passes and approved. So thank you so much for the board's policy direction. And so, as I mentioned earlier, a lot more will be coming in the future on sort of the opportunities of fleshing out the details. It is hard to make a number of different surveys of 50 different states into 2 sentences about what Washington State would preview on a very complex topic, but appreciate sort of the direction that the board is setting for today. Yeah, Michelle?
Mr. Chair, I just want to catch your, I think was a verbal amendment to the motion and make sure that that was incorporated for the record, that it was a pre and post meaningful
ongoing.
transaction. So
Yeah,
just
pre-post and ongoing.
Yeah.
Yeah.
Thank you.
Thank you, Eileen. Make sure those cattle are in the barn. We got them in the barn. Okay. Before, again, I think we're coming up on time. I just want to thank all the presenters who were here today, and particularly the continued work of the cost board staff. Thank you all so much for your continued work to prepare all the stakeholder advisory meetings. I'll just note for the public who's joining us online today, and for others who may be watching this afterwards, there will be a recording of today's meeting on the webpage that we invite you to watch. And if board members or other members of the public have additional comments after today's discussion, of course, we do have the cost boards inbox that you're welcome to share comments to the agency. And as we look ahead to some of the other bodies that are happening, the primary care and as Michelle mentioned, the Stakeholder Advisory Committee will be meeting in August to continue to get updates on the cost board's work, and we hope you can attend those as you all are available. And we will see you back here on Wednesday, September 23rd from 2 to 5. If you can attend in person, that'd be great. We'd love to see you. If not, we'll always have virtual available. And with that, I'll adjourn the July 22nd meeting. Dr. My name.